So my name is Colleen Lee. I'll be presenting today, and thank you all for coming today. I know everybody's busy, so thank you for making the time to come over. And I am a new faculty member for the School of Nursing. I've been here since January, and this is the first time I've done like a lunch and learn presentation, so I appreciate your patience if I start fumbling around. So why am I presenting on this? So a little bit of my background, I worked as a floor nurse in a detoxification rehab unit for a long time, and I had never done that. It was a acute care psychiatric hospital that morphed into a detox rehab facility while I was working there, so I had a lot of on-the-job training. And it turned out that I loved working in that field. I never thought I would, but I just fell in love with it. I was working there when I was going to school here to become a psychiatric nurse practitioner, and when I graduated I started working at the Center for Healthcare Services, and if you're not familiar with that, it's the local MHMR, but when I worked there we treated the underfunded poor of Bexar County, and a lot of those patients had addiction issues, and I left there and came back a few years later, and I started working in the specialty court program, so that I wrote up there the drug court, mental health court, and solicitation court programs. And I would say in all those programs, about 99% of my patients had some kind of addiction issue, as well as mental health. But most of the time, there's a reason why people are arrested and then get in trouble, and usually it's some kind of drug reason. My favorite court program to work with was the drug court. Judge Ernie Glenn is amazing. It was a lot of collaborative care in working together. And so my side was about treating the patient with medication and with case management therapy. And then on his side was, trying to help them go to groups and stay on track, and if they relapse, they would get kind of penalized, but it wasn't like a punitive thing. They were trying to keep them out of jail. I mean, basically that's the point. But I loved doing that work there, and Judge Glenn was a really great supporter of some of the different medications that I'll be talking about in just a little while. Not all people in the justice system are as big proponents of using medication to help treat people who have addiction. So also in my career, I sought out a mentor to teach me motivational interviewing skills, and I'm sure, that's like the big, buzzword, right? But it's not something you can just read about and start doing, which is what everything I had done was in school and just trying to read on my own. And she worked with me to get better at doing that. I still have a long way to go, but I learned a lot just from her. So, and another big passion of mine is trauma and how that affects our population, especially with people with addiction. I went to several conferences that focused on trauma and addiction, and it was just fascinating. Because what I don't understand is most people, when they're little, they don't say, "I'm going to be a heroin addict when I grow up," right? They don't say, "I'm going to be a prostitute when I grow up." Things happen, life happens, and things get really, really rough. And and I'm talking about the worst of the worst. Not everybody who has addiction has that level of trauma, but there's something going on that, for that substance use to kind of get to become a huge issue in someone's life. I kind of mentioned this already, that I work closely with case managers. LCDC stands for Licensed Chemical Dependency Counselor. They're specialized training, if you haven't heard of that before, they're specialized training and working in people who have substance abuse issues and how to help them stay in recovery, work on recovery. And then also one of the other big thing that we did, one of my really good friends who's a therapist I used to work with, she was a big proponent of trauma therapy. Cognitive processing therapy was the one that she specialized in, and we saw some really great results with that. It was fascinating. So I've always been passionate about this. I don't know why. I've even had people ask me if I'm in recovery myself, just because of how much I'm just like a proponent, and I'm not. But I don't know why. I just am really passionate about this topic. So hence me talking about it. I think this is the forward. Yes. Okay. So when I was asked to do kind of a presentation, I went to one of the Health and Wellness Committee meetings, and one of the suggestions there was, don't assume that people who come know what opioids are. So that's why I wanted to go over this today, because being on this Health Science Center campus, I would, a lot of people know, I guess, probably have heard of what opioids are, but maybe don't necessarily deal with them on a day-to-day basis. So that's why I wanted to go over them just a little bit. So of course, opioids were developed to treat pain. And of course, they do a very good job of that, certain pain. But then things got out of hand, and I'll go into that just a little bit. So there's natural opioid pain medications like morphine and codeine. Then we have the semi-synthetic ones, such as oxycodone, hydrocodone, hydromorphone, and oxymorphone. Those are some heavy-duty ones. Methadone you've probably heard of, which is what is used to help people stay off heroin and other opiates. And then another one that I don't know if you've heard in the news, but fentanyl is a really strong pain reliever, and it was not intended to be used lightly. That's heavy-duty pain medicine, and now it's being manufactured illicitly, and I'll tell you more about that in just a second. But it's deadly. Using it is deadly. So I have a list of the most commonly used opioids. Tylenol 3 is a good pain relief, but it has a little bit of codeine in it, so it's not as bad as some of the other ones that are pretty high potency. Okay, all opiates come from the opium poppy, and they're or chemically created to be like a drug that comes from the poppy. They affect the same part of the brain, and so it's pain relief and then a feeling of euphoria for most people. And then also that's another way it can cause overdose, because what happens is if people take too much, it eventually it suppresses your respirations, and then eventually you stop breathing, and then if you're not rescued, you die. So, okay, so if you just scroll down slowly, you can see that there's this one unit of morphine here. Okay, so that's their standard of reference. So then as you scroll down, thank you. So if you keep going, it's showing you like codeine is that much times stronger than morphine. Okay, hydrocodone is what was a big, hugely prescribed for a long time, but now it's being cut back. And then oxycodone. And then if you keep going, methadone is the one we talked about that we use to treat heroin addiction. Heroin is 2 to 5 times stronger. Okay, this is a medication that's used to help treat people with opiate addiction, but I mean that is how much stronger than morphine it is. You can abuse it, but it's not. That was not the intention. Then there's fentanyl. Fentanyl is like an ultra big pain relief, and this is the one that's being manufactured illicitly on the streets, in different countries and being sent over. No, because that's an appropriate use of fentanyl, right? But we're talking. I'll show you in just a second. I have a thing, but yes, it's a good question. So carfentanil is I think it's the elephant tranquilizer, but it's another medication that's being abused. But if you scroll down, you'll see how much stronger it is. So all of these are one thing of morphine, but it just keeps going and going. Yeah. And thank you. So that's the end. Thank you. Yes, ma'am. Thank you. I appreciate that. Thank you. Yes, ma'am. So carfentanil is obviously way more potent than morphine, but it's also another one that's being made illicitly and getting on the streets, and people are dying from that too. So I have more information about fentanyl, but I just thought that was a really good infographic. At least for me, pictures help me kind of in relation. So now I got some of this information from a naloxone train the trainer I went to a few weeks ago, and they were very kind to let me use some of their information on this slide. So, but I did, of course, give them credit. So 1 out of every 3 opioid prescriptions is being abused, and this is data I think from 2015. So it's not super outdated. Baby boomers are 4 times more likely to abuse opioids than millennials. That to me was surprising. Patients with psychiatric diagnosis are 3 times more likely to abuse opioids, and I'd already known that working in this field, but it's good for other people to know. Opioid abusers have twice as many pain-related conditions as non-abusers, and that's something I've seen over and over and over and over in my practice is people who got some kind of injury, sorry, and then they didn't realize they were going to get addicted, but they got addicted to the pain meds and then got cut off or couldn't afford care anymore, so then they went to the streets. I saw that over and over and over, which is really unfortunate. So those living in the lowest income areas are twice as likely to abuse opioids as higher income areas, and then they're also likely to live in the rural South than any other region. So let's see if I can, yeah. So this is one of the slides. This is from a report that I reference at the end, but this is again from the naloxone training guys. And if you can see the top 25 cities, right? But if you think about where this is in relation to a big importer of drugs right here, Mexico, right? And then another thing that's hitting the East Coast really, really bad is illicitly made fentanyl from China, which is being put into heroin on the streets, and it's like white China, and it's easier to hide than heroin here in Texas, which is usually the black tar. But it's this illicitly made fentanyl that is being mixed in, and because it gets you a better high, repeat customers, but it's also what's killing people. So it's happening a lot on the East Coast. I remember hearing about that more at a conference I went to in 2016. They were talking about this, and then of course now, the influx. But it's starting to happen here too, in San Antonio, South Texas, excuse me. The heroin that's on the street is changing from like what we call black tar to like a more of the white powdery substance that you can mix in the fentanyl with. So, so if you think that we don't have a problem, you're wrong. And one of the things that the gentleman talked to us about was that they think that Texas, some of the data on the heroin, people dying from overdoses here is probably not as accurate as it could be. So, anyways, so why the fuss? People are dying. So this is some of the data I looked at on the CDC website. It was talking about around 66% of the 63,000 drug overdose deaths in 2016 involved in opioid. The thing that really struck me here was the deaths from the overdose are reaching levels similar to the HIV epidemic at its peak in the 80s, which is alarming. And I don't know if you've noticed, but in the news, opioid deaths, it seems like it's coming in more and more in the news, and I used to think of it as more because I was, I just paid attention, but I think it's permeating, which I think is good. I think it's important that we talk about it. Texas has the country's highest rate of maternal mortality, which includes deaths during pregnancy and childbirth in the year following delivery. Maternal mortality nearly doubled between 2010 and 2014, and they were saying that the leading cause is drug overdose. And this is one of the articles I was reading because I wanted to know why maybe Texas was saying we didn't really have a big problem with opioids. And this article I was reading was talking about how this is like a big clue that that data is not correct. Like opioid issues are a big deal here. And I don't know how many of you know who Lisa Cleveland is, Dr. Cleveland. She's the one who told me about this training that I went to, and I was already interested in all this, but I know she does a lot of work with the Mommies program, and she was telling me that there's several women who OD'd in the pickup line to pick up their kids at the Healy Murphy daycare. I mean that's just right there. They're picking up their kids. So, it's awful. So, overdoses have become the leading cause of unintentional deaths in the United States. And all these big organizations, and with the SAMHSA, CDC, all these big organizations are saying this is the epidemic of our generation. And I'm glad it's finally getting talked about. Here's some more information from the CDC talking about the waves of heroin use, and then it switched to prescription. So this is when the 90s in the 90s when docs were told, oh, these aren't addictive, prescribe them, so they've been prescribing away, right? And then it was too much, right? So then 2010, they started having people overdose and deaths on heroin, and then now it's moved to fentanyl. And when the push against prescribing opioids, the analgesics, happened, like a lot of docs and other prescribers, I should say, unfortunately cut back, which means a lot of people went to the streets to get their pain relief. I mean, I'm not saying it's the wisest choice, but if you're in pain all the time, so kind of led to an increase in heroin use. And of course, the other thing is people are buying what they're told is hydrocodone or whatever on the streets, but it may not necessarily be that. Also, fentanyl's being mixed in. So then the risk of them ODing is quite high. So here is, this is the same, this is a lethal amount of heroin, and then this is a lethal amount of fentanyl. So I don't know, like on Facebook for a while, I saw some articles flying around about some of the police officers, I think it was on the northeast coast, who were having to get in, like suit up to, because the inhalation of, they didn't know what they were inhaling, but most likely fentanyl, if it was in the air, they could, possibly OD just from that. And I had heard that stuff before, but when I talked to the Naloxone guys, they were also saying, they kind of confirmed that it's that lethal, it's that dangerous. So, okay. So why is this happening? Like I mentioned, there was a big push. Like I remember when I was in my undergrad nursing school, I remember they were talking about pain as a fifth vital sign, and we're always assessing for pain. So then, that's good, we need to treat pain. But then, there was a big push of the prescription. Hydrocodone was probably the biggest one. Now, like I mentioned earlier from the map, illicitly manufactured fentanyl is being trafficked from Mexico and China, being mixed in with heroin, but it's also being mixed in with other stuff like meth and other pills. And like I said, they're doing this because they can buy the manufactured fentanyl cheap, mix it in with other stuff, and the high is more intense, so people want to come back to them, and they drop their other dealers, right? But then they don't know they have the fentanyl in there, and they're dying. So it's a pretty awful problem. The other thing that's near and dear to my heart is people lose access to health care all of a sudden. How are they going to manage pain? How are they going to be able to go to the doctor or a nurse practitioner to get pain treatment? The other thing is that what's flabbergasted me is the lack of the push of medication-assisted treatment, or MAT. It's a short term for it. Like medications besides methadone. It seems like everybody knows about methadone and they have a certain mindset about that, but there's lots of other things like Suboxone. There's another one called naltrexone. I know they sound very similar. They work a little bit the same, but they're very effective in helping people stay and wean off opioids. I'm sorry, my throat's squeaked. I know in Texas, at least in South Texas here, in San Antonio, the amount of treatment centers we have is pathetic. It's awful. And the thing about addiction is if somebody's ready for treatment, they need to go like then, right? Not wait. And that's something that is a big problem, that people are having to wait. And then, of course, they relapse, and then they may die while they've relapsed. So the other thing is that there were some docs I heard of, and I'm sure y'all have heard of this too, they call them pill mills. People go and they just get tons of pills. And the docs don't care. They just write a script and get money, and they're done. That's awful, but it was happening. So the DEA cut down on that. So, excuse me. This is something that's another pet peeve of mine. I don't know if you've ever seen this infographic before. If methadone is free to addicts because they have a disease, why is chemo not free for cancer patients? So, one, methadone is not free. I have yet to find a place. And if anyone knows of one that's free, tell me, because I will send my patients there. So methadone is not free. So, but I thought this was a good reflection of how I think society as a whole treats people with addiction. Just kind of shove them off to the side like it's not an important thing. Like, and the methadone is free. I don't know where people get this from, but I've seen people who are in my field of work comment on this like it's actually true on Facebook, like that's an accurate information gatherer, but still, I'm shocked. I'm like, really, you work in this field and you're supporting this? Like, this is not true. So I don't know if I'm explaining myself very well in that regard. I just think our society shuns and shames people for addiction when they don't have to. And addiction can come in many forms. It doesn't have to be illicit substances. It can be food, it can be sex, it can be work. It's just those are not illegal. But addiction shows up in all kinds of ways. It's just our society has a way of pushing people and punishing them. The other thing is the word addicts. That's another pet peeve of mine, because you are not your disease. I mean, you don't walk around saying, oh, that person who that cancer person, no, that person with cancer. So with somebody who has addiction, you say they have addiction disorder, but you don't call them an addict. Something I thought was interesting, Janis Joplin and Jim Morrison, what they think was suspected heroin overdose, right? Janis Joplin was heroin. So Prince, right, for people of my generation know who he is. He died of a fentanyl overdose. Tom Petty, fentanyl and oxycodone.
What about Michael Jackson?
Michael Jackson was propofol. Propofol is a sedative that's used to, every time I used it in ICU, it was on a ventilated patient. But that's what he died from. But this, again, kind of sometimes I think society is more forgiving of people who are famous with addiction than just, your general everyday folks. And I don't understand that either. They're people too. So, and I suspect that Anthony Bourdain, I think they have not come out and said, they said suspected suicide, right? But I think it was an accidental overdose, because he has a history of addiction to heroin. So what's being done? Well, at least nationally, I know some stuff was going on before this, but then in 2015, the DEA has issued a nationwide alert on fentanyl as a threat to health and public safety. Thank goodness. And then just in April of this year, the Surgeon General was promoting the use of naloxone, Narcan, as an opioid overdose reversing drug. And I thought that was funny because I was driving to work and I heard it, and then Heather emailed me and was like, did you hear the Surgeon General? So I thought that was really amazing that the Surgeon General of the United States has actually said something about the use of naloxone. And then the Department of Health and Human Services has released some more funding for the United States to help promote the efforts to combat the opioid crisis. So in Texas, our governor signed into law this bill that it's supposed to increase the access to Narcan or naloxone. It kind of gives the ability of pharmacies to dispense this without an actual prescription. And for those of you who don't know what naloxone is, or Narcan, if you're not familiar with that, it's an opioid antagonist, and it reverses the effects of opiates. And you can give it intranasally, you can give it IM in the muscle. The training I went to where they were dispensing tons of Narcan is intranasal, because you can give it a lot easier and then you wait for a few minutes to see if it reverses. Now, the opioid use of abuse, usually you can give somebody one dose and they respond, they revive. But with fentanyl on board and sometimes a mix of benzodiazepines and some other substances, they're saying that first responders are having to give dose after dose after dose just because the stuff is in their system so much. But I think it's pretty awesome that, in my opinion, Texas is a pretty conservative state, and finally we're doing something about this to help people, and that we had a training here on campus, and there were tons of first responders there, UT police, I think there were police from Incarnate Word, and the whole point of that training was to train the trainer so they can go out and train, because it's a big deal, and it's so much so that they're wanting people to carry naloxone with them, because if you see somebody on the floor and you're not sure, it's not going to hurt them to give it, you'll put them into withdrawal, but at least they'll be alive, And so the gentlemen who did the training, they are really awesome, but they're part of this Texas Overdose Naloxone Initiative, or TONY. And they go all over Texas doing training on naloxone to help people start using it and teaching it themselves. And they also do like on the street work with people who are on the streets to talk about the use of naloxone and give it out to them, because people are dying and they don't want people to die. They want people to survive so they can hopefully one day get help and not be an addiction anymore. So Dr. Cleveland is on the Joint Opioid Task Force, and she told me about it, and I want to join it. But it was developed by Bexar County and the City of San Antonio and the University Health System to help start working on what's going on here in San Antonio, which I think is pretty amazing. Also, I attended this, and it was sponsored by the Joint Opioid Task Force, but it was in April, and they provided training for this medication here called buprenorphine, or the brand name is Suboxone, and that's another medication that you can use to help treat people with opiate addiction and help them with cravings and not relapse. And you have to have special training. MDs have to have a certain amount of training, and then NPs have to have additional training on top of that. And it used to be NPs couldn't prescribe it, but then the law changed because this is such a big thing that they're allowing us to start prescribing it now so we can increase the access for people. And then I told you about the train the trainer session. Okay, so I listed some resources here if you wanted to know more about the Tony. I listed their website. If you know anybody that has a loved one who passed away from overdose, I thought this was a really good website. And then, of course, there's SAMHSA. MedDrop SA is where you can dispose of unwanted medications safely, because they encourage people to get all the opiates out of your house that you're not using so that nobody steals them and uses them, right? Or your kids don't get to them. And then the Joint Opioid Task Force, they have a website, which I don't know why the link didn't show up, and I apologize for that. But they have some good information on their website too. And this is something that the Tony guys gave us, but it's a little cool infographic to help when you find somebody unresponsive and you want to, give them, administer naloxone. And I meant to bring it today, and I forgot, so I apologize for that. And here's my information, my email from here if you have any questions that you think of, maybe not now, but later. And so now I didn't want to put a whole lot of information on here and get too detailed because one, I didn't know like the total audience, like who would be coming, but also I wanted to leave time for questions if people had questions. Yes, ma'am. So the community-wide, there's a big grant to push naloxone out. That's what Dr. Cleveland got for here. So that's part of it. And that's what those Tony guys have. They got a huge amount of money from the government to help push and give out the naloxone for free for people who can't afford it. And so we can, I can order some for our clinic. I just haven't figured that out how much to get, but we can. Now the cost depends on out-of-pocket cost if you're just gonna go get some. It depends on the delivery. The ones that are IM are a little more expensive, and then the nasal I think is like $30 or $40 a pop. And of course, because there's a higher demand for naloxone now, they bumped up the price. All the medication companies who make it bumped up the price. So the cheapest way to get it is in a vial that you can draw up, but it's like a multi-use syringe. But I guess most people would prefer just the easy administration, right, of the intranasal or the IM things. But yeah.
One kind of dose.
Yes.
Intranasal.
Yes.
Kind of thing.
Yes. 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 So it used to be much cheaper.
Yeah, it's been around
Forever. Yeah, I used it in the ICU. I mean, that was the only time I gave it when it was an IV, But yeah. Did I answer all your questions? Okay. Anybody else? Yes, that's part of the push from Tony. They even have cards about how to use naloxone. Yes, it's the push to give them to people to have, and also to talk to family members about how to use it, so that in emergency, they can have it on hand. They even talk about people with addiction to carry it with them, and they even have talking to people on the streets who are using to talk to them about, okay, if you're gonna go use, don't both of you shoot up at the same time. One, watch, because in case there's fentanyl in there, then you can revive them, and because if you both, but I mean, they're going to that extent, and but also for other family members. And I really think it's wise. Why not have it? Why not have it on you? And if you, this is something that the gentleman brought up, which I think is true. They said the only reason why this is getting so much attention now is because white middle class kids are dying, which I have always thought, but it was nice to hear someone else say that. Because for a long time it was just, oh, those people over there, right? But anyway, so now, at least now it's getting some attention, great. But I have a friend, a dear friend who, he's a physician in Houston, and I think his son abused opioids, but also benzos. I mean, and he's middle class, you know, hello, you know, it can happen to him, it can happen. We have another friend whose his son overdosed, you know, and it can happen to anybody. And I think it's better to talk about it and have it ready to go. Why not? Why not? It's better than having a dead kid, a dead loved one. It's a good question. Heather, were you going to ask something? It reverses the effects of the opiates on those receptors in the brain. Yeah, so it reverses the effects. So then all of a sudden, like the effect of the opiates are gone, and it's like they're like don't have any opiates in their system. Does that make sense?
If something were to happen to them where they're in pain, you couldn't administer anything to them to block that pain after giving them the Narcan. You know what I'm saying?
You could. You would have to, well, and that's, okay, so somebody in addiction, especially with opiates, it's hard to manage their pain because their tolerance is so high. But in that situation, you would probably be more concerned if they were alive or dead versus in pain. Because when you administer Narcan, naloxone, you're putting them into withdrawal right away. So they're going to feel horrible, you know, but they're breathing and they're alive versus, and they're not going to be happy, right? But at least at that point in time, they're not going to feel good at all. But yeah, does that make sense? Did I? Okay.
How much dosage is necessary to reverse this? How many times should they take it?
So it depends on how much they have in their system. But with the Narcan, the naloxone, they say, I don't know how much, I think it's 4 milligrams that's in one dose. And you wait 1 to 3 minutes to see if they start responding. And you're doing, if they're not breathing, you're doing emergency breathing for them, and then see if they come back. If they don't, then you administer another dose. And hopefully by then, EMS, EMT, you know, are coming to help, you know, so they can help with the breathing and such. But it just depends on how much they have in their system.
And you can test that by doing the lab test, how much they have in the system? How do you know how much they have?
You have no idea.
Oh,
Because
okay.
they're overdosed and they're lying on the street or in a house, in a car. They're basically, you know, dead.
You just have to wait for it.
And so before fentanyl came along, you know, like 1 dose would be enough for heroin, right? But fentanyl is now being mixed in and all this stuff, and a lot of stuff people have no idea it's in, like methamphetamine. So people who are wanting to get really high in that regard versus the high from heroin, they don't know fentanyl's in there. And they OD. They have no idea that, you know, they're going to stop breathing. Yes, and that happens a lot, unfortunately. But you never know, it could be that one time that they, yes. And I didn't put this in here, but in the training, it showed a video of a young woman that was revived. She was on the street and they revived her, and then they were interviewing her. She got into treatment, and she had been sober for like 6 months, but they were talking to her, the people who saved her were talking to her, and she's like, I had no idea that I was dead. I had no idea that you did all that, you know? And she there was like, thank you, because I'm glad to be alive now, you know? It was really, I'm getting goosebumps just talking about it. So, yes.
Is there any?
Well, thank you for coming today. I appreciate you asking questions, and I hope I answered them well. And but thank you again for taking the time to come today. Thank you.